Hello, ladies and gentlemen. It's my pleasure to be with you tonight about a very fantastic webinar regarding nutrition in renal transplant patients. Because actually, I attended many conferences in intensive care nutrition, but I never hear topic talking about renal transplant. That's why we gathered all experts all over the world to really give the best talk about nutrition in renal transplant patients, especially kidney. It's very valuable. Always we are talking about kidney is a superstar organ. It filters around 180 liters per day and reabsorb about 120 liters per day. So if the kidney failed and start to replace by another kidney, this time is very crucial to win and to maximize all aspects of care, including nutrition. So we will talk about 5 minutes regarding the fellowship, Intensive Care Nutrition Fellowship, which is hosted and created by World Intensive Care Society. It's called World Institute of Critical Care and Emergency Medicine. The institute conducting many fellowship. One of them is Intensive Care Nutrition, and is going to start soon in May 26. And why Intensive Care Nutrition Fellowship? Because critical ill patient is living at the edge. There is only one chance to improve his survival. There is no second chance. So we feel that it's very, very important to maximize all aspects of patient care. Both adults and pediatrics and neonates actually is present in the fellowship, so it's very unique. We open the fellowship worldwide, so all over the world. And the syllabus is very rich. We'll talk about 3 modules. The first module called Foundation of Intensive Care Medicine. We'll talk about enteral, parenteral, special subcategories of patient. The second, we'll talk about total parenteral nutrition in adult, pediatric, and neonates. And the third module, we'll talk about advanced critical care nutrition, and we'll tackle all really aspects of special subcategories of patient. Detailed program, I don't have time to share it, but it's very rich, and advise all of you really to register at the fellowship. So the fellowship team is actually coming from all over the world. We have a big, great diversity. We have actually intensivist, internist, endocrinologist, GI physician. We have clinical dietitians. All of them are very senior in the field of critical care. We have clinical pharmacists also who are very senior in the field of critical care nutrition. You can take a look on the team in front of you quickly. We try to gather the best people all over the world. And the fellowship is actually American accredited, 96 credit, 32 credit for each module. And we have lecture, we have journal club, we have actually MCQs, we have clinical scenarios, we have a monthly live webinar. And it was a great certificate in critical care nutrition.
Discover the next level of critical care expertise with the Intensive Care Nutrition Fellowship, a phenomenal program for aspiring professionals in the field. With the increasing importance of nutrition in critical care, this fellowship fills a crucial void in training. It's not just a program, it's a deep dive into advanced clinical nutrition knowledge. The fellowship covers everything from basics to advanced concepts of nutrition for adults, children, and newborns, tackling questions about various critically ill patients across different specialties. This includes medical, surgical, cardiovascular, renal, hepatic, oncological, transplant patients, and more, encompassing both enteral and parenteral nutrition. Upon finishing, attendees will be capable of confidently and securely formulating nutrition plans and managing any related complications. Join the fellowship to reshape healthcare and transform your dedication to patient care into a leadership role. Critical care nutrition. Whether you're a beginner, or a seasoned professional, this program offers the perfect platform for growth. Your path to becoming a healthcare innovator is just a step away. Don't let this chance slip away. Embrace your future in critical care nutrition with the Intensive Care Nutrition Fellowship. Your journey to becoming a healthcare hero starts here.
So please follow us on social media, LinkedIn, MailChimp. We have monthly webinar. We started really the first webinar. We talk about renal nutrition, novel therapy, renal nutrition. And then the second webinar, we talk about oncology, critical care nutrition. And the third webinar, we'll talk about renal transplant. It is my pleasure to introduce Professor Hisham Sayed. He is the president of Egyptian Society of Nephrology, and he is one of the most expert physician in the world in the field of renal transplant. That's why we invited him to moderate the session today. And we also, it's my pleasure to introduce Rafa, is my great friend. She is the president of MERBI, Middle East Society, our Alliance of Enteral and Parenteral Nutrition, and is the most famous nutrition specialist in the Middle East and one of the best all over the world. So floor is yours, Prof. Hisham and Wafa. Thank you very much. And start, please.
Thank you very much, my dear friend, Professor Khalid. And it's very important that to tackle this topic and very unique topic, how to do a nutritional support for our patients on renal transplantation programs, especially for those who are on long journey on dialysis with loss of many of nutrients and minerals who are going to for transplantation, and those are deprived with chronic kidney diseases with protein restriction and more. So I am very interested in to hear from all of our professors here, and we'll leave that for Professor Wafa to continue the journey with these topics. And I'm sure that by the end, we'll get more and we'll learn more from that. Thank you very much.
Good evening, everybody. It's my honor always to be with you, Dr. Khalid, my dear friend, and our speakers and our attendees from all over the world, and my dear Dr. Hisham, my colleague in moderation for the tonight session. Actually, the medical nutrition plays a very crucial role in the management of patients who have undergone renal transplant surgery. And I thank Dr. Khalid for such an amazing topic because it's really needed. We all know that poor nutrition is essential to support the recovery and promote long-term graft function. And also it reduces the risk for complication post-transplant. So today we will see a lot of speakers who will take us in a tour about the nutrition and about the transplant and how we will take care of it. Our first speaker is a dear friend as well, and she is a prof who I know her for a long time. Her name is Professor Mireille Caravetian. She's a clinical researcher specialized in nutrition, which with a focus on the health promotion and management for non-communicable chronic diseases. She earned her PhD in the health promotion and also hold a dietetics degree from the American University of Beirut. Through her career, Dr. Mireille had worked in various Middle Eastern countries. She's also a main organizer in MAPEN and the scientific committee. She have a lot of researches. She's currently serves as senior researcher associated at the faculty in University in Toronto. Her researches employ both qualitative and quantitative methods. I will leave the floor for Dr. Mireille to take us on a tour for the nutrition for the transplant, and she is our main speaker. I hope the recording for Dr. Mireille is ready, and all the questions will be at the end for after all our eminent speakers. Myself, Dr. Hisham, and Dr. Khalid will take you on a tour. Keep your questions ready. We will rock it today.
There is no voice.
Yeah, can you please check it? Thank you.
While sharing.
The pre and
Yeah,
post
now it's fine. Now it's fine.
Now, as a reminder, I'm sure you all know, but as a reminder that kidney transplant is a donor kidney is given to the person whose kidney is absolutely not functioning, and that person starts having a new kidney that can actually provide and support their life. Now, when it comes to nutritional assessment, which is today's main scope of the session, there is screening, anthropometric, and there is biochemical, and there is dietary screening. Now, I will talk quite in detail about each one of them. So, but first of all, let's understand what are we looking for. When we're talking about somebody who's doing a surgery, we need to focus on malnutrition, making sure that the person doesn't have malnutrition so that once they go to surgery, their body is ready with their optimal health to make sure that the surgery goes well without any complications. As you can see here, 1 in 5 patients only, let me see how I can show my there you go. My pointer, only 1 in 5 people in the hospitals have formal nutrition screening, which is very sad because that means that 4 out of 5 are being overlooked and not being given early aggressive nutrition therapy. Their nutritional needs are not being met on the right time. Only 1 out of 5 patients receive any preoperative nutrition intervention, okay? And all of this, if we provide nutrition intervention, it costs very little, but yet if we don't provide, then it costs the healthcare a lot, and obviously the patient's health outcomes. Now, the impact of surgery on nutritional status, there is metabolic changes because of the surgery, and then adequate nutrition plans for surgeries would include severe surgical stress increases muscle and fat breakdown to provide energy for wound healing and enhance the defense against microbes. Malnourished patients have insufficient amounts of muscle and body fat. Therefore, they may not appropriately respond to surgical stress. Patients at risk for malnutrition may become malnourished as a result of surgical stress, okay? And the surgical stress, when I talk about, it is here that we mentioned, the muscle and the fat breakdown, okay? This is something that I was very happy to be invited to write a book in a chapter, and I would like to share this diagram that I've been able to draw. Now, inflammation, if we follow inflammation, it increases cytokines and cortisol. Cytokines decreases appetite and energy intake, and cortisol increases insulin resistance, hyperinsulinemia, and decreases glucose uptake by the tissues, which causes for the tissues to be starving. Now, what does this do? The body thinks that it's in a fasting state or in catabolic, basically. So glucagon increases. Now, when glucagon increases, these are the things that happen. So protein breakdown, fat breakdown, carbohydrate, not intake to the muscle. So hyperglycemia, hyperlipidemia, and high protein in the urine, turnover, muscle loss, but also increase in urea, and the pH decreases, the blood becomes acidic. When the blood becomes acidic, always remember that it can lead to multi-organ failure, because it is as if our organs are left in an acid. So be careful with that. Now, the transplant has a few stages. The nutritional status, basically. Pre-transplant, there's something, and then acute phase is something, and then chronic phase is something. So in the pre-transplant, we want to make sure that the person has good nutritional status, meaning we're preventing malnutrition and obesity.
I can't hear it.
Please unmute yourself, Dr. Khaled.
To possible hyperactive parathyroid, because they would have had most probably parathyroid issues and managed side effects of medication. I will talk more in detail about that, at least for the ones that time allows. Now, pre-transplant, what do we need to do? We need to make sure that we look into the medical history, the diet history, anthropometrics, biochemical indices, nutrition supplementations, and information about renal replacement therapy of the person prior to the surgery, and accordingly formulate a recommendation. And always make sure that the person is not malnourished, because that will increase their complications post-surgery. Even the adaptation of the graft or the acceptance by the body. Now, when we look into what is how do we start with the nutritional treatment? First of all, we have to screen for the patient. Now, I work in Canada, so I would like to share the Canadian guidelines. With the Canadian guidelines for the Malnutrition Task Force, what they say is the Canadian Nutrition Society says this is a nutrition guideline, nutrition screening form, which is very, very simple. That says, has the person been losing weight in the past 6 months, if you see my pointer? And have you been eating less than your usual for more than a week? Okay, so if it's a yes or a no, okay, if it's a yes, then the person will have to be assessed. If it's a no, great, but then put a date that 7 days later you want to re-screen them. Okay. Annotate, yes. Okay. Now, the Canadian guidelines is that, and the European guidelines says something else, which is, sorry, I need to take off this, which is the nutrition risk screening tool, and it's very similar, and it talks about BMI, weight loss, reduced dietary intake, but also takes into account if the person is ill. Now, if the patient is screened to be at risk, the next thing is assessment, okay? When we go to assessment, we always have to make sure what are we assessing to, the reference body weight, okay? Now, with all chronically ill patients, we have to make sure that the BMI is a little bit elevated. So the BMI for chronically ill patients with high inflammation, like renal failure, like a surgery, like cancer, we need to make sure that we're abiding by 22 to 27 BMI, not the 20 to 25 usual. Okay, so you want to leave a cushion, like a safety cushion, to make sure that there is the person is not falling into malnutrition. So standard body weight would be kind of a replacement of the ideal body weight as a reference weight that you want to compare to when you are looking at the person has achieved the right weight or not. So this is just an example about a person, a female, let's say 165 centimeters, around this age, and this should be their, and the medium frame size, this should be their standard body weight. Having said that, so after screening and after identifying what is the reference body weight, we have to look into assessment. Now, assessment, right now, one of the assessment tools is GLIM, a Global Initiative for Malnutrition. And what it does, it says that has the person had any involuntary weight loss or low body mass less than 20, weight loss involuntary somewhere between 5 to 10%, and reduced muscle mass. We'll talk about how to estimate muscle mass reduced. And then etiologically, has the person been reducing food intake, and is there a disease? Now, if the person has one of this as a marker and one of this as a risk thing, then the person is considered at risk. And then the next thing would be moderate or severe. The person would become severe if the phenotypic, see this one, the phenotypic criterion is determined as severe. Now, how do we do that? Here, there you go. So the phenotypic ones are in detail. So weight loss, if it's 5 to 10% in the past 6 months, it would be moderate malnutrition, and more than 10% or in 6 months, or more than 20% beyond 6 months is severe. The same concept for BMI and the same concept for muscle mass. Okay, so for you to understand how you can identify a person being from the previous screening tool as no risk or at risk, and then when it comes to at risk, deciding if the person is at moderate or severe risk. And here it is, the GLIM comes in hand. Now, with the muscle mass, I said that we need to understand if the person has reduced muscle mass. With reduced muscle mass, how do you estimate it? You can estimate it with a bunch of tools, which I'll share in the next slide. But before that, let's look into what are the metrics. The metrics are appendicular skeletal muscle mass, DEXA, BIA. With the BIA, you can estimate the fat-free mass index, which is just like the BMI, but instead of the weight, the total weight divided by meter square, we will look into the muscle mass or fat-free muscle mass, and then divided by height meter square. Appendicular lean mass that comes out again from many BIA machines and so forth. So these are the numbers. You can take a screenshot if you wish, and these are from the sarcopenia guidelines. Now, what are the tools that we can understand muscle mass with? One of the ones that I really like and it's very easy to use is hand grip strength, but there's also an advanced one, BIA. BIA can actually give you what is the appendicular skeletal muscle mass compared to DEXA, or sorry, this is from DEXA, and the FFMI, this one can come from a BIA, and this is a DEXA. Okay, and also something that is emerging these days is phase angle, but phase angle hasn't found itself yet in the GLIM guidelines, so we can just think about it, put it in the back of our head, but not focus on using it as part of the assessment, at least for malnutrition right now. Basically, phase angle tells how the liquid in the mitochondria is healthy, and the phase angle, the machine sends an electrical current to the muscle, to the tissue, and how acutely that angle of that reaction of the electrical current comes back. So the wider, the worse, and the more acute, better. So the conductivity of the mitochondria, that's what it's looking at. And if there is a lot of fat or inflammation in the mitochondria, then the phase angle will show that poor metrics, okay? So for the muscle mass in the GLIM, we looked into hand grip strength. These are some examples. BIA, and BIA can give you a fat-free mass index, or even phase angle, and DEXA, quite advanced machine, not every clinic has it, can give you appendicular muscle mass. Okay, so these are from sarcopenia guidelines on how to identify muscle mass. Now these were the how to understand the malnutrition, right? So now that we have the patient, now next thing is to understand exactly like an algorithm in a hospital setting, what to do with the patient. A patient planning for kidney transplant comes over, what do? You assess for metabolic syndrome, okay? More than 25 BMI. Before I go down, does the person have a good BMI? Yes, great. Before going ahead, does the person have a very low BMI? If yes, then 18 for younger people, 20 for older adults. Then we have to look into weight gain, and that has to go for nutrition support, which will be the lecture after me. I will not focus on that. Okay, if the person has a good BMI, maintain. If the person has a good BMI or a high BMI, either way, we have to check if their waist circumference is high. If the waist circumference is high, then we have to give them medical nutrition therapy for obesity. If that is sorted out, then the next thing is that we have to make sure that their triglyceride is not high, they don't have dyslipidemia, and HDL and LDL are perfectly fine. And these are the numbers for every males and females. Their blood pressure is fine, and fasting blood sugar is fine. I think you understand these. So we have to make sure that we're preventing obesity, dyslipidemia, hypertension, and diabetes. Why are we doing this? Because if a person has all of these and they go into surgery and do the kidney transplant, very quickly their body can end up rejecting. So there's a preparatory phase for the person to be ready for the surgery, so that the surgery is a success. It's not a joke to put a new organ from a donor to a person. So we want to make sure that the body's perfectly ready to make the best out of it. Now, if there are blood tests that are not okay, excuse me, then we have to sort that out. We can look into the medical nutrition therapy guidelines for renal patients according to the stage of kidney disease for that person. Poor oral health, then we have to look into nutrition supplements, which is the next lecture after me. And declining strength, we have to work with the physiotherapy team to make sure that they are encouraging physical activity. Okay, and once we've sorted all of these out, then the patient is eligible for kidney transplant from nutritional perspectives. Okay. Post-transplant, what do we do post-transplant? Yeah. So post-transplant, we've got two phases. We've got the acute and then the long-term. The acute is providing and supporting the body as a post-surgery treatment, okay? So we have to give high protein and let me bring my pointer back. Yeah, high protein, high calorie, carbohydrate, somewhere between 50 to 70%, depending on the medication they're taking. I'll mention a little bit more about that. And then fat complementing all the others. Now, very often you might not need such a high carbohydrate. It might be that you might actually go to 45%. And I personally am more inclined to 45%. Now, long term, somewhere between 0.8 to 1 gram, basic RDA, still high calorie at the beginning, at least for a while, to make sure that they are not going to malnutrition, but carbohydrate can go a little bit lower, and therapeutic lifestyle changes, diet for cardiovascular disease is, and to prevent diabetes and obesity and dyslipidemia and hypertension would be the right way to go to make sure that we protect the body moving forward. There is at the beginning in the immediate phase, the electrolytes, we have to make sure that they are within normal. So you do not know if you need to intervene or not unless you do blood test. Once you do blood test, you will know if you need to intervene or not. So do not take it for granted that if the person has done kidney transplant and they're good. No, you have to look into it. Sometimes either their medication would do complications or their body, that's how they react, okay? And with the long term, you have to make sure this is, again, the immunosuppressive medication, what they're doing to the metabolism of the body, and if there is hyperthyroidism and it's causing hypophosphatemia, to make sure that you actually individualize the diet according to their needs. Immunosuppressive therapy, very often they have a lot of nutritional side effects that affect the intake, like diarrhea, nausea, vomiting, GI infections, ulcerations, fungal infections, candida, esophagitis. One of the most common ones is corticosteroid that I will be talking about because they take a lot of immunosuppressants. But one of the ones that we can talk about, we don't have time to talk about all of them, is about corticosteroids, okay? The corticosteroids, they give sodium retention, enhanced appetite, hyperlipidemia, hyperglycemia, protein catabolism, gastrointestinal ulceration. So what to do? We have to make sure that the sodium intake, the sugar intake, the fat intake is tailor-made to their corticosteroid dose. If they're taking less than 10 milligram, which very rarely that happens, they usually take high doses, then we have to give them a low-salt diet. But if they're taking 10 to 20 milligrams of sodium, then low salt, low sugar. 20 to 60 milligrams of corticosteroid, then low salt, low sugar, and low fat. And more than 16, then all of that, but always make sure that there's always adequate supply of calcium, because corticosteroids actually cause calcium excretion from the body. Grapefruit enhances the absorption of these immunosuppressants and a lot of medications, up to 20 to 45%. So it can be used if the body is resistant to some medication, but it can also cause toxicity if the person is taking it without understanding the uses of it or the effect of it. So you want to make sure that you explain to your patient that grapefruit cannot be abused. Food safety, sometimes they end up having food safety issues and you have to give them a neutropenic diet, which is a sterile diet, mainly cooked. They cannot eat uncooked fruits and vegetables unless they are sterilized. And last but not least, exercise prescription. Moderate intensity aerobic exercise 3 times a week doesn't differ from general population. If they have done a transplant, kidney transplant, doesn't mean that they cannot exercise. Okay, so they should be exercising. They should be living the best, healthiest, optimal life that they can. And on top of the aerobic exercise, they should have at least 2 times a week weightlifting and using repetitions of 8 to 15 times to make sure that they maintain their muscle mass. Thank you very much for listening, and I will be here for questions and answers. Thank you.
I thank Dr. Mireille for the speech, and I think the floor now for Dr. Hisham. Dr. Hisham, you can unmute yourself, please. Yeah, thank you. A reminder.
Okay, thank you very much, Professor Mary. It's a very enriched material. We think that our doctors in nephrology departments should look for this talk very, very closely, because you touch many of the points and you highlight in sarcopenia and end-stage kidney disease problems. So I thought that this is one of the biggest nutritional support for our patients on transplant. Now, if we are talking about fluids, our daily practice of prescribing fluids, but who is the expert to guide us and drive our information for that? No one better than Professor Manu Malprin, who is a senior consultant intensive internal medicine president of the Internal Fluid Academy. Professor Manu, one of the pioneers and the co-founder and the president of the International Fluid Academy. So we got the key from the pulse of the fluid treatment. Is also the co-founder, past president, and current treasurer of the Abdominal Compartment Society. We know that abdominal compartment is getting more and more exercising in our ICU. He has thousands of lectures, international scientific meetings. So please, Professor Manu, we need to know from you a lot of our interest in the media and the field of renal transplantation.
Hello, ladies and gentlemen. I'm Manu Malbrin from Belgium, and it's a real pleasure to give a lecture on why and how chloride content matters when we are administering intravenous fluids. I'm senior consultant intensivist in the first department of anesthesiology and intensive therapy at the Medical University of Lublin and co-founder and president of the International Fluid Academy. As said, I'm an internist intensivist from Belgium, and for disclosures, I have to state that I receive speakers' fees and consultancy fees from different companies. So let's kick off with an introduction and why are we giving fluids? Fluids should promote stroke volume, or maybe others would like to give fluids to improve tissue perfusion. Of course, Fluid will increase stroke volume, improve macrohemodynamics, and thereby also improve the oxygen that will go to the tissues because it's balancing the macrohemodynamics with the microhemodynamics. And we know that sepsis is a time-critical emergency, like other medical conditions, myocardial infarction or ischemic stroke, where you have a couple of hours door-to-needle time. Polytrauma, we need to have a full-body CT. And when it comes to sepsis, we have a 1 hour door-to antibiotic time or door-to IV fluid. And maybe this is kind of a golden hour where we can preserve oxygenation and perfusion for the organs. It's kind of deeply ingrained in our brain, and it comes from the blue stage of spasmodic cholera, where we saw that these patients are profoundly hypovolemic and fluids are life-saving. Yet, when we are administering fluids, in responders, non-responders, you have a transient increase in cardiac output that fades away after a couple of minutes. And the Andromeda study showed that while 2/3 of the patients were fluid responsive on admission, after 4 hours, only 4% remained fluid responsive. So we should only give fluids when there is acute circulatory failure, when there is tissue hypoperfusion, the patient is fluid responsive, fluid tolerant, and there is no risk for fluid accumulation syndrome. And if we can assess, patients should, of course, also have hypovolemia. Only when these conditions are matched, we can give fluids. But fluid accumulation syndrome is a syndrome. It's not a disease. It can occur within many conditions and disease states. Yet most surgeons, anesthetists, maybe also some intensivists. Let's illustrate with the typical patient after abdominal sepsis, perforated vicus, gets back to the ICU and blood pressure is low or urine output or CVP is low, or the patient may be fluid responsive. At the end of the day, the patient may have received 5 bags of saline. Why is that? Because it's kind of a reflex. Whenever something goes wrong, we believe that some fluids are good. On postoperative day 2, we see that the abdomen is distended, creatinine is increasing, and by day 4, there is oliguria, positive cumulative fluid balance, further deterioration of kidney function, and CVVH is started. On day 7, there is sudden cardiac arrest, and the patient received a decompressive laparotomy in the ICU because of acute mesenteric ischemia due to intra-abdominal compartment syndrome due to fluid accumulation syndrome. So abdominal hypertension is a killer, but did you do everything to prevent fluid accumulation syndrome? And due to everything to prevent hyperchloremia, which is the topic of my talk today. So we need to shift our mindset and start thinking fluid stewardship. Lecture is all about breaking bad habits. And for this purpose, about 15 years ago, the International Fluid Academy was founded with a mission statement to promote research, foster education on fluid management in critical patients, thereby improving survival. So the focus is on education, research, and international collaboration. One of the reasons I got an interest in fluids is that when I was a medical student, I exactly received 0.0 hours of education and training. One patient in 5 will suffer from complications of inappropriate fluid administration, which could be too little or too much fluid. And that's why we should look at fluids as antibiotics. We are all very familiar with antibiotic stewardship. The same we can translate to fluid stewardship, the drug dose duration and de-escalation. A recent survey with over 1,000 healthcare providers from all over the globe showed that the average knowledge score was only 46%. So we didn't pass the test. To err is human. Humans make mistakes, but let's forget a mistake and remember the lesson. For that, the International Fluid Academy provides some guidance and guidelines on fluids in sepsis, on fluid stewardship in the perioperative phase, in COVID patients. We also support research on maintenance solutions in healthy volunteers and critically ill, a review on fluids in abdominal hypertension, and a recent paper was on how to translate this to the bedside and how to implement fluid stewardship. I'm very proud and happy that the open access book, since it was launched last year, has been downloaded 1,370,000 times, which tells me 2 things. People like it when it's for free, but also that people and colleagues are interested to learn more about fluid stewardship. So the topic of today is whether in critically ill patients, a chloride restrictive fluid strategy compared to a chloride rich strategy will result in better outcomes. So less AKI morbidity and mortality. Brings me to the 10D framework on definitions, diagnosis, distribution of fluids, the drug, the dose, the duration, and the de-escalation. The 4 from the stewardship that we know of, antibiotic stewardship. The 8 is on documentation, the diligence is carefulness we treat fluids, is the stewardship and power of 10, and this is what I should call fluid stewardship. This is what you and I should be doing in the hospital, in the ICU. So about definitions, we know that body fluids, the intrinsic fluids, they are vital. You know that the lungs takes up the oxygen then goes to the central circulation, the GI tract takes up nutrients, and these nutrients, this oxygen will go to the cells, the waste products are getting rid of by the kidneys, and the CO2 is exhaled via the lungs. So fluids are essential for transportation, regulation of body temperature, and as a medium for food digestion. From the extrinsic fluids, we have 4 types, like the crystalloids. We can talk about balanced or unbalanced, which is the saline and the high chloride containing fluids. They could be hypo to hypertonic. We have colloids, we have blood products, and we have nutritional fluids. So I will talk mainly about crystalloids and the chloride content. If we look at the composition of fluid electrolytes, we know that sodium is the major cation for the extracellular fluid, where potassium is the major cation for the intracellular fluids. And the other important cations like calcium, phosphorus, magnesium are also intracellular, and we know that hydrogen phosphate is the main intracellular electrolyte, and chloride is the main extracellular anion that interplays with the sodium. So when we are giving fluids to our patient may end up with fluid overload, hypervolemia, hyperhydration, and peripheral edema. And while hypervolemia, because of hydrostatic forces, always leads to peripheral edema, the opposite is not true. It's not because the patient has edematous that he or she is intravascularly overfilled. So maybe we should avoid the term fluid overload, and everything you need to know about the new definition can be found in this open access paper on de-resuscitation and a recent review on fluid accumulation syndrome. New definition of fluid accumulation instead of fluid overload is an increase in body weight or cumulative fluid balance in relation to baseline body weight. Maybe we could look at other things like edema, blood volume, or volume excess with bioelectrical impedance analysis. We know that most of the fluids are intracellular, 1/3 extracellular, out of which a quarter is the intravascular fluids. When we talk about fluid accumulation, we refer to the extracellular water, whereas hypervolemia relates to an increase in intravascular fluid. Fluid accumulation syndrome is any degree of fluids that have accumulated with a negative impact on end-organ function, with or without a global increased permeability syndrome. And in the recent review on FAS, this is the visual abstract where we learn that fluid accumulation syndrome has an impact on all organ functions, and prevention is key, with restriction of fluids, withholding, withdrawing, and then, if needed, de-escalation and de-resuscitation. So there are many more definitions, and for time's sake, let's move on to D2, which is the diagnosis. Hypovolemia is bad because oxygen can't get to the tissues because of convective problems, and hypervolemia may be worse because you have diffusion problems and oxygen can't get to the tissues either. That's why the prediction of fluid responsiveness is important and the fluid status matters. But there are many myths and misunderstandings, like not all septic patients are hypovolemic. They may just be vasoplegic. This is a very nice video showing that if you give vasoconstriction, by squeezing the bottle, you increase the stressed volume, you recruit from the unstressed, and you increase venous return. Peripheral edema doesn't mean that the patient needs to be given diuretics. And a low preload doesn't mean that we need to give fluids. Just because you're fluid responsive doesn't mean you need fluids, or that you're hypovolemic, or that you are fluid tolerant, as these terms can occur in any combination. D3 is about the distribution of fluids. And for this, we need to know the difference between osmolality. versus tonicity. So the osmolality with the formula there will determine the tolerability of a fluid, whereas the tonicity or effective osmolality, mainly driven by the sodium, will determine the distribution. I told you that the human body mainly consists of water, 2/3, and most of the water is intracellular, 1/3 extracellular, out of which 1/4 is the intravascular. If we would administer 1 liter of isotonic saline and we check after 1 hour, about 25% will remain intravascularly. Whereas if you give a hypertonic solution, this will mainly go to the intracellular space and only 8% will remain intravascularly. So this is good for cellular dehydration. Colloids, we assume that at least after 1 hour, they remain intravascularly about 100%. You could translate this. So what if you would like to increase the circulating blood volume by 1 liter? So you either need to give 12 liters of glucose, 5 liters of saline, or 1 liter of colloid, for instance, albumin. D4 is about the drug, and we shouldn't cause harm to the patient. So there are only 4 indications to administer fluids. First is for resuscitation to save lives. Second one is routine maintenance to cover the daily needs of glucose and electrolytes and water. Third indication is replacement to mimic the fluid that is lost. And the fourth indication is nutrition, but there's another indication, which is dilution to dissolve other drugs like antibiotics, painkillers, and so forth. Remember that all fluids are redistributed, so we need to reassess. In a recent study done by Niels van Regenmortel was found that from all fluids given to ICU patients, about over 10,000 patients, 3% is blood products, 6% resuscitation, maintenance replacement 25%, nutrition 33%, and another 33% is what was called fluid creep, fluids that seep into the patient to dissolve other drugs. So 10 years ago, the debate was ongoing between colloids and crystalloids, whereas today the discussion mainly goes between chloride-rich and chloride-poor solutions, so saline versus balanced solutions. Balanced solution is a solution that has a strong ion difference, which is around 26 or more, compared to saline with a strong ion difference of 0. We call them chloride-rich versus chloride-poor solutions. So the question whether hyperchloremic metabolic acidosis exists, there's a lot of literature, but does it clinically matter? There is not so much literature until almost a decade ago. The studies by Shaw and Yunus were published. So now we have a little bit more evidence that hyperchloremia isn't good. I told you about the Yunus paper, which showed that compared to controls, there was a higher difference between sodium and chloride, so which is the strong ion difference mainly. So pH was better, lactate was better, as well as base deficit. In the study by Shaw, looking at composite endpoint, there was a significant favor of plasma-light compared to saline, as well as other interventions. And also mortality increased the higher the chloride levels. After this came the big fluid trials with the split, the SALT, SALT-TD, SMART, Basics, and the PLUS trial. But this was followed with a systematic review, meta-analysis of these individual trials, showing that in patients with sepsis, there is a clear preference for balanced solutions, not so in patients with traumatic brain injury. If we look at a post hoc analysis of the SMART study, and we combine the trajectory from the ER to the ICU, then there was a clear difference in chloride and levels, as well as hospital mortality. In post hoc analysis of the Basics study, where they also looked at patients who received balanced and kept on receiving balanced solutions, this was also better in those receiving only balanced solutions. Putting all this together, the 6 randomized trials, we see a 1% reduction in mortality. This is with a 90% probability. Balanced solutions are associated with a reduction in major adverse kidney events, especially if you take the trajectory from the ED and ICU, especially in sepsis, burns, patients with DKA, in patients with traumatic brain injury and ones on neurocritical care. Saline is still a good first choice. If we look at the content of free sodium in 1 bag of saline, it's about 3.5 grams, as opposed to 2.3 grams, which is the daily need. So it's nothing normal about saline, and it has dramatic effects on all organ function. It is a drug. So maybe it's about time to stop this abnormal saline, because it will increase sodium balance, it will increase chloride levels, it will decrease renal perfusion, lead to acidosis. Because of the positive sodium balance, this is followed by a positive fluid balance, increase in potassium levels, and an increased risk for AKI, evidenced by increases in biomarkers. Also, the vasopressor need is increased in patients receiving saline. So the question is, if chloride-rich fluids are not good, what is then the ideal fluid? I don't know the answer, but maybe the 5-liter bags that we use for CVVH come close. And theoretically, the ideal SID should be around 24 millimoles per liter to keep plasma pH neutral. Saline, on the other hand, having a SID of 0 will result in metabolic acidosis. So maybe in the future, the discussion will go on the buffer. What is the best buffer? Lactate, pyruvate, citrate, acetate, malate, succinate, gluconate. There is a lot of misconception, as some colleagues think that these buffers are referred to as bicarbonate precursors, but their role is not to generate bicarbonate, but to disappear rapidly, so to exert a strong ion difference effect. So now going to guidance and guidelines, if we look at the recent European Society Intensive Care guideline on fluid therapy, first part is on fluids for resuscitation. Second part is on the amount, so the drug, this is the dose. And the third part is on the de-escalation, so the duration and the escalation. The recommendations are that balanced crystalloids should be used rather than saline in adult critically ill patients in general, and especially those with sepsis. For neurocritical care, saline is still a good first choice, and in patients with kidney injury, also balanced crystalloids. If I would ask you, what is the risk of administering a balanced solution with potassium in a patient with AKI and an increased potassium level? Let's have a look. Theoretically, if we would have 1 liter of plasma with this composition, and we would add on top of that 1 liter of saline with a SID of 0. If we would now mix the two, and we would have 2 liters in total, then the SID will be reduced because of the high chloride content. pH will drop. You could say, okay, you have 1 bag of saline, no potassium, and you have the increased potassium, so you can have dilution, but because of the hyperchloremic metabolic acidosis, potassium will increase. Whereas if you have 1 liter of plasma and you would add 1 liter of plasma light, then you will see that because of the chloride pool content, the pH will increase. And because of this increase in pH, you can look at the dilution factor. It's still good because 5 is less than 6, but because of the metabolic alkalosis, you will see a reduction in potassium. So D5 is the dose, and Paracelsus already nicely stated, everything is poison. It's the dose that makes something to become poisonous. In the studies that we performed with Niels van Regen model in healthy volunteers on top and ICU patients, and if you look after 48 hours, then you see positive sodium balance comparing saline with hypertonic balanced solutions. And this will result in a positive fluid balance in healthy volunteers, 600 ml, ICU patients almost 1 liter in 2 days. So that's why in Belgium, you always get the beer, we don't have wine, with the salty peanuts, making the beer isotonic. So you are more thirsty because of the salt, you drink more, you pee less, you stay at the bar. It's a win-win. D6 is about duration. So we shouldn't give fluids to treat the numbers, like in the case drop in blood pressure, CVP urine output, but to treat shock. And D7 is about de-escalation, and here comes the Rose model in play, is the different phases of fluid therapy. After resuscitation, which is life-saving, comes the stabilization, optimization, and then the evacuation. It's like giving water to the flower, the rose, the blossoming, and then just the rose at the end as a dry rose, not a dead one. Very happy to see that the Rose model has been picked up by other colleagues like in neurocritical care, and it's all about setting the right targets, triggers, and using the right safety limits in order to reach the goal, which is to avoid global increased permeability syndrome. Because fluid accumulation at the outside will mirror fluid accumulation at each and every organ system, and this is global increased permeability syndrome. That's why peripheral edema, anasarca, is not cosmetic, but it's bad medicine, or it may be a biomarker for critical illness and ongoing infection inflammation. In fact, patients have been shown to be drowned in excess of saline, as was this unfortunate case. D8 is about documentation, and you probably all know that this is the Little Mermaid in Copenhagen, where lives Anders Perner, and they looked at the issuing of isotonic fluids, so the balanced and unbalanced one, and majority was chloride rich, about 70%. I had to look this up, but this is Beautiful 5 in Scotland, where lives Marsha McDougall, and she implemented nice guidelines and fluid stewardship in 5 in Scotland. You can see that sodium consumption is decreasing. They switched Hartmann with Plasmalite, and they gave a hypertonic balanced maintenance solution when needed. By doing so, they saw a reduction in fluid administration and cost savings, recurrent about 80,000 British pounds, and from 5 to 3.7 liters per stay. So the clock is ticking and we can do better. What we should do is implement fluid stewardship, which can be defined as a series of coordinated interventions introduced to select the optimal fluid dose duration of therapy that results in the best clinical outcomes, prevention of adverse event, and cost reduction, like antibiotic stewardship. So it's all about the right fluid at the right dose, right rate, duration, and indication for the right patient at the right time. D10 is discussion, which is mainly about leadership, as fluid stewardship is a change program, and this is summarized how to do it in this expert panel report with 13 steps, identifying the clinical leads for starters, and following the different steps. Basically is a startup phase to take a snapshot of the actual situation, do a knowledge test, strategy planning, and then prepare for the change. So to wrap up things, I hope I convince you that IV fluids are not just innocent bags of water. They are not, they are drugs. They come with indications, contraindications, and potential adverse effects. When it comes to fluids in sepsis, there's probably no space for starches, gelatins, saline in large amounts, or hypotonic solutions. For resuscitation, we should use isotonic balanced. In TBI and neurocritical care, saline can be used. Maintenance, if at all needed, hypertonic balanced, and we should avoid fluid creep. But the strategy is more important than the fluid itself, also in DKA and AKI. Having said that, I invite you to join the International Fluid Academy with a lifetime free membership. Thank you for your attention.
Thank you very much, Professor Manuel. You let us to think several times before prescribing saline and other fluids. You touch a very important points and critical points, and I will borrow from your words that not all edema need diuretics. The important is to right prescribing that from the start I think that we will get some experiences from this talk, and we are changing our practice depending on very amazing and very informative, illuminating talk. Thank you very much, and keep with us for question and answer. Professor Wafa.
Thank you, Dr. Hisham, for this. My God, I enjoyed the talk of Professor Mano. It's one of really insightful. Yeah, I love it. With that, I'll take you to another special speaker. All our eminent speakers today are amazing. Professor Elizabeth Dewell, and she's gonna give us a talk about the novel nutrition therapy and renal disease. Our dear professor, she have a lot of achievement. I'll summarize them in this. She is the founder and a head of clinical nutrition department at Brussels, established the multidisciplinary department 2021, integrating care for hospitalized and ambulatory patients. She's the medical director of intensive care at Brussels, oversees critical care with focus on nutrition metabolism in severely ill patients. She had a PhD in clinical nutrition and metabolism. Her thesis focused on energy expenditure and nutritional therapy in critical ill patients, advancing knowledge in ICU. Over 100 peer-reviewed publication. She have the executive. She's in the executive board member of ESPN. She is an international speaker and educator. Her CV is full of knowledge, and she can take us in another important role of nutrition for the novel of nutrition of transplant. The floor is yours, Professor Elizabeth.
Hello, my name is Elisabeth de Waele. I'm a surgeon intensivist and clinical nutrition expert from Brussels, Belgium, and I'm delighted to join you and the other excellent faculty members to give a presentation and to talk about nutrition in renal transplantation. So the honor is really mine to be with you today. So first of all, of course, what are we talking about? Nutritional therapy can be oral nutritional supplements, enteral nutrition, and parenteral nutrition. So let's have a look. Those, of course, are my disclosures in research and clinical work. Now, if we are talking about the patients who are in need of renal transplantation, who have undergone renal transplantation, what is their profile and why is nutrition so important? Well, of course, we can have a look at the guidelines of the European Society for Clinical Nutrition and Metabolism, and you can already feel that patients that you know so well with acute and chronic disease of kidney disease are especially prone to malnutrition. Because you can see here that there is a statement that indeed the patient who has a kidney function impairment has negative effects on the metabolism. So the food that they are eating, the food that they are receiving is not metabolized as other patients or normal, not healthy, not diseased people would show. So there is already a difference in protein catabolism, the immune system, and so on. So patients in need of renal transplant who are undergone renal transplant, they have already a high risk of being malnourished. Now, why is that? You can see it here. There is a very high level, as you know, of protein and energy wasting in your patients. Because first of all, they might have reduced food intake, but they also have lifestyle and comorbidities that may contribute. They don't move a lot. They have restrictions in their diet. So this is already, all of it is contributing to this energy and protein wasting. The fact that they have a chronic disease will also change their metabolism and have a real impact. So you can see here that the prevalence of protein energy wasting is high, and that the profile of your patients really leads to malnutrition. Now, more in the field of metabolism, we can see in this publication that indeed when you measure the metabolic rate of patients who will have renal transplant, they could show, and you compare the measured value to the equations, you can see that patients have already a quite higher energy expenditure. And this is probably to be explained by the chronic disease they have. So it's very important to know the metabolic rate of your patients because this will help them when they need a nutritional therapy. Now, this paper from 2023 showed indeed that it is important to know if your patient has a high risk of malnutrition, yes or no, because the outcome of the transplant will be different in a patient with a high or a low malnutrition risk. You can see here that you can start with BMI, but BMI is not very specific. So we will also look at lab data and clinical data. So you can actually use this kind of checkboxes to see if your patient is a high risk for malnutrition, yes or no. And those are easily accessible data. You don't need the whole technology that a nutrition department might have. So this is quite easy for you. Why would you want to calculate this? Well, let's see here, because the impact is big. This is on graft survival. So how well will your graft survive? And you can see the follow-up in months that when you have a patient with a high malnutrition risk, the risk is almost double as high to lose the graft and to have no good survival. So you can see the difference in the upper part of patients who do not have malnutrition compared with patients who have moderate or high malnutrition. So yes, it is very relevant to know the malnutrition state of your patient when he or she is going into transplant. Now, if you look at the mechanisms, and this is once again from the guidelines, it is important to see, are there action points? Are there points that you can tackle? Is there some kind of action that you can do to change the situation? And from a nutritionist part, I can show you that, in fact, anorexia, people not feeling hungry, is something that you need to know because it can change your strategy. The restrictions, we are moving away from the very strict diets because we know that patients with chronic kidney failure, the adherence to the diets, it's not very good. And it's also possible that the impact of having a very sane diet may not be as high as we have always thought. So this is important to know. Like I said, the increase in energy expenditure, if you know that your patients are consuming more and more energy, it's very important to know or to measure that, because it means that they will have higher nutritional needs. They will get more nutrition than if they were not in this state of hypercatabolism. The same is true for cancer patients. And you know, if the intake and the metabolism is not in a good balance, patients will lose a lot of weight, including muscle mass. The reduced uptake, you need to know how much energy and protein your patients are actually receiving. By eating, by oral supplements, you need to know how much, because then you can make the ratio. And also the comorbidities, such as diabetes, are very important when you will start a nutritional therapy.
Khaled, please back again the video. It's not shown.
Yes or no. So we talked about the profile, and we know that the patients are prone to malnutrition, and it will affect the outcome. Now, the transplant itself is, of course, a surgical procedure, and we know about malnutrition and surgery. We know, for example, that when you look at patients, once again, who are in a state of malnutrition, and they have surgery being done, the patients who are malnourished will have a much higher mortality in the months after the hospitalization and the surgery when compared to patients who are not malnourished. Of course, it can be a cascade of events, of post-operative infections, and so on. But you know that malnutrition is something that undermines the entire body. So indeed, it is quite easy to understand why these numbers are so high. And also, there's not only the impact on the patients, there is also the impact on society and the healthcare economic impact, because when a patient will have complications such as infections, you will know that the length of stay will increase, you will need antibiotics, you will have a higher cost, and essentially malnutrition leads to higher healthcare economic burden. So both from a patient perspective and a healthcare economic, it's very important to know the malnutrition or the nutrition status of your patients. Now, this is an important slide that I got from my good American friend, Paul Wischmeyer, but I think it's very relevant. Let's walk it through. So first of all, surgeons, and especially transplant surgeons, they know about the fact that perioperative nutrition will reduce complications. You can see it in green. 3 out of 4, they know it. And they also know that when you invest in a nutritional therapy, you will have a return on investment, which is very high. Nutrition is very cheap intervention. We are not chemotherapy. We are not large infrastructures. We are nutrition. So the return on investment is very high. Now, besides the knowledge, there is the clinical action. And then we see that only 1 out of 5 patients receive any nutrition in the perioperative period. So we are not actually doing what we know. Especially, of course, the high-risk patients, such as GI surgery, they have a high risk of malnutrition, but we have just seen that also your patient's profile has a high risk of malnutrition, and that indeed there is a 3 times greater risk of having a complication and even a 5 times greater risk to die than patients who are not in a state of malnutrition. But once again, our infrastructure can change and we can improve. And our hospital, like 20% of other hospitals, they have a formal nutrition screening process. So you're actually looking for patients to screen for malnutrition. So this is important data, the knowledge is there, and the implementation can be done in a systematic way. Now, if we know that the profile of your patients is very vulnerable, we know that surgery on a complicated patient, a surgical procedure on a malnourished patient will have a large impact. What can we do? How will the nutritional therapy look like? And this is next. Now, once again, let's go and stick to the guidelines. From our Brussels perspective, we would look at the European guidelines, but this time you're looking at the clinical nutrition guideline in surgery because your patients will have a surgical procedure. So let's have a look if also those guidelines can help you with an intervention. Now, of course, some of you know, and most of you, about the enhanced recovery after surgery. And you know that in this whole trajectory of interventions, there is an important role of nutrition. And of course, you need to talk to your anesthesiologist, to your nurses, to the patient themselves, because everybody needs to cooperate. But it has been shown in many centers that it is possible to have a positive interaction between healthcare professionals and to actually think and make a difference for the patients who are the most important people in the hospital. So pre-admission nutritional support is important. Also letting the patients drink carbohydrate drinks before surgery. And of course, after the surgery, return to eating and drinking quite rapidly. But of course, for your population, this might be feasible. So both in the guidelines and in the ERAS system, there is a huge opportunity for nutrition. First thing, you need to know which patient will benefit from nutritional therapy and which patient will not need it and will not benefit from a nutritional therapy. So you need to screen your patients so that you can assess them and that you can have a treatment. Now, this is a global, so around the world, a global leadership on malnutrition. And you can use this wherever you are to screen for malnutrition. It's more complicated than it looks here, but overall, what you are looking for in your patients is weight loss, low BMI, or muscle loss, so people are not so very strengthful as they used to be. If you have one of those parameters, you combine it with an absorption problem, for example, a GI disease or another state why they would not absorb very well, or a low intake, or the presence of inflammation of disease, which is always the case in your patients, you will have a positive screening for malnutrition. So one from the first row, one from the second, and you will have malnutrition. So that's an easy way of screening your patients. Now, this is more complicated. It comes from the guidelines, and you can check them online, the European Society guidelines. What it actually shows you that is when you have a surgical patient, you have opportunities in the pre-operative period and you have opportunities in the post-operative period where you can have decision trees on consider nutritional therapy. Consider nutritional therapy before surgery or during and after surgery when you don't have time. So what it tells you that you would have a nutritional care plan once your patient is on the transplant list, so that you already have the available information on the metabolic need, on the preferences, the food preferences of the patient. And then afterwards, after the transplant, you can use all this information to have a good nutritional therapy. So what does it look like? For example, post-operatively, when the patient is eating quite and drinking quite quickly, you can say, okay, let's continue like this. But if you see that for 5 days, they're having a very low intake, or 7 days, less than half, and this time moves quick, you have to go into nutritional therapy. What can you do? If it's possible, you will always use the gut and use enteral nutrition. But if this doesn't work, then you have to switch, and you can use some supplemental parenteral nutrition, which is intravenous nutrition, just to overcome this time where the patient is going up. And then you need to know, of course, how much energy you should give and how much protein. And this is why you need to know your information from beforehand, because it can move quick and you need to have the information. So you will always use oral nutritional supplements if possible, otherwise enteral or intravenous nutrition, and in a standardized and protocolized way. So this is what the guideline will tell you. This is a special cases, especially also for kidney transplant, which we're talking about today. And you can see that early intake of food is recommended within 24 hours. So this is a strong consensus. Your patients should be eating and drinking within 24 hours. So this is really also a clinical cutoff. If it's not possible, you will need enteral or parenteral nutrition. As you can see, it should be combined, because patients might be eating, but what they are eating is very limited if you really look at it and if you calculate the energy and the protein content. So very important to objectify and to know how much is it that your patient is eating. And if it's not enough, you will supplement with supplemental PN or enteral nutrition. Now, can we be smart? Because in the medicine of today, we don't need to be many, we need to be smart. So what about artificial nutrition? How can you use it in a smart way? How to know where to go? So let's have a look at the possibilities of clinical nutrition. First of all, you have the normal food with the healthy vegetables and the oils and so on. This is for people who are able to eat. And of course, you have the fish and the dietary products, and then the things that are no good have to be restricted. So this is what dietitians do. They will work with normal food and use high protein and high energy nutrition. So this is, of course, the first step. If it works, okay, but please objectify how much your patients are getting. What are we doing with artificial nutrition is, in fact, replacing normal food. And these are the components of normal food. This is what you are giving to your patients. And here is where the medical decision-making is coming up. You need to give a certain amount of carbohydrates, amino acids, lipids, vitamin, mineral trace. So this is everything that you will be prescribing and that you will be providing to your patients. Now, energy and protein, I've mentioned it before. How to know it when you are a medical doctor in charge of renal transplant? What will you do? First of all, you will know how much energy to give by indirect calorimetry. And if you don't have it, which is the gold standard, if you cannot do it, use 25 to 30 kcal per ideal body weight per day. This is once again a recommendation from the guidelines. So you have a number, 1,600, 2,200. This is the amount of energy your patient will need in 24 hours. The other thing is protein, because your patient has to heal. The patient has to heal the wounds and has to come back from surgery. So you need protein, 1.5 gram per kg of ideal body weight per day. And then you will end up with 70 or 100 gram of protein per day. So you know what you have to prescribe to your patient. Now, this can be like, once again, in normal food, you can combine normal food with oral supplements. You can use enteral nutrition also at night, for example, that your patient is able to eat during the day and then you fuel them during the night. Or you can use parenteral nutrition, once again, as a supplement or as a total parenteral nutrition. So those are the options that you have. It's a little bit like antibiotics. You can take the pill, and if you cannot take the pill, you will give it in an intravenous way. So it's just the route that is different, but the intervention, the nutrition is the same. Once again, you have a large variety in oral supplements, in enteral nutrition, and in parenteral nutrition. So you have a lot of choices. And the good thing is that if you need a certain amount of energy and protein, you can look into the possibilities and see which one is the best for one single patient. Now, the patient will be your guide. You don't actually need to decide, I will give this or that. The patient will guide you. If your patient is eating and you see that it's enough, because most of the time it's not, but if it's enough, let them eat. If it's not enough and they can tolerate oral supplements, give them oral supplements. Some patients will need enteral and some patients will need parenteral. The patient will be your guide. That's a very important part of clinical nutrition therapy. Now, this is how it is stipulated for critically care patients, for ICU patients, but the concept is quite the same. If the patient is unable to eat, you start with enteral nutrition. But after a few days, you see if it's not working out with enteral nutrition, you put this supplemental parenteral nutrition on top to meet the total energy expenditure that you have measured by indirect calorimetry or you have calculated on the body weight. So this is how we do it in intensive care, and this is how you can do it in your patient. You just use the route that is valuable for that patient at that time point. Now, you can also, of course, work together with clinical nutrition experts. For example, in our hospital, we have a department of clinical nutrition where we see transplant patients before the surgery. So like I said, we do the body composition, we do indirect calorimetry, we do all of this, and then we are ready for when the transplant is being done. What are we doing? We are, like I said, following the guidelines. So we will do indirect calorimetry to know the energy expenditure and to guide your nutritional therapy. So this is for the energy part. You also want to know how frail your patient is by body composition analysis. Like I said, is there a loss of muscle force? Is there a loss of muscle mass? You can know it by doing a 3-minute test before the surgery. So this is something that traditionally nutrition experts would do. And then you also have, if possible, you will have dietitians, you can have online consultations, you can monitor and coach your patients to be ready for the big day of their transplant. Now, one thing I would like to mention is if you're giving your nutrition, of course, you are very careful because your patients are frail and you don't want to have negative side effects, especially not, for example, on the liver. And this is why I show you some recent work we have done with pharmacists looking at parenteral nutrition and, for example, the liver, because you're providing nutrition, but it might have an impact. And this is something we would like to know. And this is some lab work that showed you, and that maybe it's too early to translate to clinical practice, but indeed, we, for example, saw that when you confront liver tests with parenteral nutrition, the lipids appear to have no effect on short-term exposure. The glucose is that show the toxicity at higher concentrations, and the amino acids had no effect in a general ICU population. So it's very important to see that if you have a short-term nutritional therapy, it might not harm your patients. But of course, we have to be careful translating this work immediately into clinical practice. Then you also have the choice, like I said, because a lot of intravenous lipid emulsions. And with my experience all over the world, I think it's very important to know what is the quality of the intravenous lipid emulsions that you have in your available products. Because soybean, for example, has been used for many decades, but in the States, they are moving away from it because it's quite pro-inflammatory. You will always need a little amount of soybean because it will provide essential fatty acids. So you don't have to go without because the essential fatty acids are present in the soybean. But then you have fish oil and olive oil, intravenous lipid emulsions, which are currently available for your patients. For the renal transplant patients, there are no exact guidelines on telling you what to do. And of course, all those products are safe. I just want to share with you that if you just want to feed your patient, you can safely use, as we do, a lot of olive oil-based nutrition. Because of course, the characteristics of the fish oil might be very interesting, but I do not have good guidance bedside to see if you would use something that interferes with the immune system. We don't even know when to use corticosteroids. So yes, it's safe, but if you want to be ultra safe, you can just feed the patients with a neutral intravenous lipid emulsions. But of course, that's up to you. Now, another word on protein metabolism, because patients need proteins. And of course, you're always very careful with proteins in chronic kidney disease patients, but the malnutrition has a much bigger impact than the rest of the consequences. So what you can see here is that the amino acid turnover is very important, and it will not only feed the muscles, but it will also feed the kidney, because once again, you need to heal, your patient needs to heal. So when you're providing amino acids, a lot of it will be used to make the GI tract more stronger, but it will also be used to heal and to help build your kidney. So it's important to provide enough proteins. Now, I would like to come to a conclusion after what I've shown you today. You need to assess your patient pre-operatively so that you're ready, that you have the information to do a nutritional therapy after the surgery. You need to invest, or you have the opportunity to invest in nutritional therapy. And investment means having investment in knowledge as you are today, invest in people who can take care of this, and also in having latest generation products to treat your patients with the best there is. You can follow guidelines for surgery and for malnutrition, or work together with experts. The most important message is that you have to know how much your patient is receiving on energy and protein, and how and what can you do to make sure that the body is well nourished so that the healing process can be optimal. So I think that when you go to the guidelines of the European Society, or you work with experts, you will make a difference in the field. You will make a difference, and your patients will benefit because of your acts. And with that, I would like to thank you for your attention, and I'm looking forward to the questions. So thank you very much for your attention.
Amazing, Professor Elizabeth. Thank you so much. Actually, we enjoyed the talk, and it was to the point, direct, clear, and it showed how much the medical nutrition really integral for the recovery process following the renal transplant, in all, how a tailored nutrition dense diet aligned with the individual in the clinical needs, the medication they are taking, and it can help to optimize kidney function. We are Dr. Khalid and Dr. Hisham. I think now we're gonna be open for the questions, if I'm not mistaken. And I saw some of the questions have been already answered by Professor Mireille on the chat, on the question and answer. But are we there, Dr. Hisham and Dr. Khalid? You are with me,
Yes, sure.
right?
We are here.
Yeah.
Yes, for sure. We
Okay,
are
very
ready.
good. Our speakers, Professor Mireille, Professor Anu, and Professor Elizabeth, you are with us, right? Okay. Can we take one?
Wafa, please, just I would like to announce Dr. Amr Al-Husseini provide us with promo code only valid for 24 hours for people who want to register for the Intensive Care Nutrition Fellowship. So it will start immediately after the webinar for 24 hours. It's called Webinar 25. You have the barcode on the screen, but you can use also the word capital Webinar 25. You get 25% discount on these 3 modules. You start from after finishing the webinar till 24 hours. Thank you very much. I'll stop share and I'll leave the floor for you, Wafa and Dr. Hisham.
Okay, so we will alter the questions, and I'll leave the floor open because it's not assigned to a certain speaker, but what the one which I have I saw, as I said, Professor Mirey have already answered some. There is an anonymous attendee have asked if the patient with graft dysfunction treated like CKD, like CKD.
Yes, definitely. A patient with graft dysfunction is considered as well CKD. So CKD patient may be transplanted as well. So all is applied for that.
Also, Dr. Abdelhamid Hamdi Ramadan asking about whether low CL and cardiovascular risk to talk or emphasize about this.
Low chlorine and cardiovascular risk.
Yes.
Professor Menu. Professor Menu?
Hello, yes. Thank you. Is an excellent question. And indeed, there have been studies that hypochloremia may, in fact, increase the cardiovascular risk. But on the other hand, increased sodium may also worsen prognosis because of positive sodium balance that may go hand in hand with a positive fluid balance. But you're right, yeah. And I realize now that I was too fast in preparing my lecture because I only noticed now that it's about renal transplant. But you can rest assured that all the recommendations for balanced solutions also hold true for transplant patients. I think there was a meta-analysis in 2024 and in early 2025 in a total of about 1,600 patients comparing saline with balanced solutions. And it was found that delayed graft function was less, acid-base disturbance was less, and also the risk for increased potassium levels. So what I said in general is also true for post-transplant.
It was an excellent presentation, Professor Manu. Professor Hisham, I'm gonna give the question and you assign it please to our speakers if you don't mind.
Yes, I will add for the, yes, I will first add for the cardiovascular risk for Abdelhamid.
Please.
Yes, we know that we are talking about not right now, not serum sodium. We are talking about tissue sodium in general in patients with CKD, including dialysis and including transplantation. So sodium in tissue carries more risk. For the chlorine, we have more and more of non-traditional risk factor for cardiovascular death and cardiovascular diseases, including uremic milieu in general. So Professor Manu answered perfectly on that. We're coming for a question from Mohammed Faris that after transplant, should the level of tacrolimus and ATG levels be monitored regularly? For ATG, we don't use routinely ATG, but if you are going to do as an induction therapy, you don't have to monitor. And for tacrolimus, you can monitor that up to 1 year. And even you can monitor later on upon changing the doses. So ATG is recommended to monitor on 2 occasions, one during the first year and second whenever you change the doses.
Then there is a question on the pH of saline and ringer lactate. I think saline with a strong ion difference of 0 is very acid. I think the pH is 4 or 5, depending whether it's in vitro or in vivo. So it's very acid. And pH from ringer lactate, I think, is around 6.5, 7. So it's more closer to physiologic pH. But I wouldn't look at pH, I would look at a strong ion difference, and the ideal strong ion difference to keep pH within normal range would be around 24, 26 millimoles per liter in a normal situation. So yes, saline is very acid, and I have no idea why we should give such a solution to our patients unless the patient is losing saline which could be the case if there is upper gastrointestinal tract losses, or in case it's traumatic brain injury, neurocritical care, then saline is still first choice as an isotonic solution.
Yes, there is another question, Professor Wafa, for the lipid emulsions deficiency in the current market. I think Professor Elizabeth can respond for that. For this question, is there is a lipid emulsion deficiency in the current market?
Yes, it depends where you are in the world to know what kind of generation of intravenous lipid emulsion you have access to. So it's very important to have this low soy. This is the most important. But of course, to have the access to the olive and the fish would be much better. I do not have any experience with transcutaneous by the skin. The application of the oil, I do not know, and I do know not literature on the absorption rate, but it is a very interesting way of thinking, because the skin is an underestimated organ that we might use more, but I do not know if applying olive oil would have a clinically significant absorption rate. This is something that I cannot respond to, because there is no big knowledge. On the other side, I do not think it might harm, because I think it's more, or it doesn't help, or it doesn't harm. This would be my personal opinion. So this is on the question for the olive oil. I think there was another question, if you want me to also answer.
Yes, please, yes, please. Yes,
yes, there is also a question on the hepatic formula to help in decrease the elevation of liver enzymes. So hepatic formula is sometimes used, but in the European guidelines, by meta-analysis, by big data, there is not really a support for the hepatic formulas. This means enteral nutrition, parenteral nutrition, which is adjusted for a certain disease state. Also for diabetes, for example, you have enteral nutrition formulas, especially for diabetes, but from an outcome perspective, there is not a big difference. And especially from a healthcare economic, if it costs much more, I would not do it. We have very good experience not using the hepatic formula, using, let's say, the general ratios between the lipids, the carbohydrates, and the proteins, and still have good results, as long as you use the latest generation of intravenous lipid emulsions.
Prof. Hisham, if you allow me just to ask.
Yeah, sure. We got the answer from the experts.
Yeah, I have a question. I'm not expert today.
Yeah.
Elizabeth, I would like to ask you about C15, the novel C15. Do you think there is a future for novel C15 in parenteral nutrition formula in the next decade?
It might be very promising, but indeed, this is more the quality of the nutrition, and this is a new domain, the quality, what will we use? But up till now, I think that there is some promising information, but not enough to make recommendations at the time point. But it is still possible that it will be in the future.
Allow me to ask Professor Mireille about the hepatic, if they are using it in Canada, the hepatic formula, and also what is the best parenteral nutrition supplementation in AKI and hepatic patient, cerebrovascular stroke. Professor Mireille, please.
Sure, thank you for the question. Hepatic formulas, yes, they are used in Canada. There's a lot of variety, and there's renal and hepatic formulas, each with different protein compositions. Obviously, the hepatic ones are more rich in branched chain amino acids because they don't overwhelm the liver. Having said that, for parenteral solutions, the problem with parenteral solution is comes with a lot of liquid. So it all depends if the patient can extract the liquid, excrete the liquid out of their body. If that's the case, then no problem. Not related to transplant, but for example, in dialysis, there is obviously interdialytic parenteral nutrition, where the dialysis patient can have an ultrafiltration of 1 liter, and then a 1 liter of parenteral solution can be given. But usually it's best to use the total parenteral nutrition compositions and not the peripheral ones, the partial parenteral, because the partial parenteral has more liquid, less nutrients because of osmolarity, and it goes through small veins. Yet the higher composition ones need, the problem with them is that they need big veins to go in for the osmolarity, but they're efficient because always with kidney failure, you are in a tug of war between nutrients and water, how much you're benefiting, how much you're hurting the patient. But if the person is not on dialysis, they're on CKD, then parenteral solution might be a problem. If that needs to be given, then definitely other ways of laxatives or some ways of removing the liquid should be given, either dialysis or medication, to make sure that the person doesn't end up accumulating all this water inside. Thank you.
And
Thank you, Professor.
we have to put in mind that the dialyzable nutrients and elements and trace elements. So patient on dialysis, it should be evaluated pre and post dialysis for the possible, as prescribed perfectly, that amino acid loss. In particularly branched chain amino acid and its deleterious effect on the CNS and post-dialysis fatigue.
Professor Elizabeth, would you like to add anything on that in Brussels, if it is different?
Yes, I agree totally with the colleague from Canada, indeed, that it is best to use the most complete 3 components parenteral nutrition with good ratios between protein, carbohydrates, and lipids, and indeed use the more concentrated product. So I think that Canada and Belgium is aligned on this topic. So I would agree. And thank you for mentioning the intradialytic parenteral nutrition. You should use it normally if you have let's say, a normal distribution of patients in around 5% of your patients. 5% of your patients would have a protein energy wasting that is so important that you could give parenteral nutrition during dialysis, around 5%.
Thank you.
And I would like to add,
here an important point, we almost using that and stressing on plus nutrition is the physical exercise, even intradialytic physical exercise. We believe that in patient with frail and sarcopenia, we cannot move the proteins to the atrophic muscle except with exercise. So we are pushing toward physical exercise during and in between dialysis. Do you recommend that plus your nutritional support to add the most physical exercise according to the patient's situation?
Professor Mireille, you wanted to add something. Can you please highlight?
Actually,
And
I
also
will
Dr.
answer.
Hisham. Yeah, I think you're going to talk about this, right? Because you are doing it, right?
Actually, I will answer this question.
Yeah.
The
Yeah,
study
please.
that I published in UAE, where I conducted interdialytic exercise. So during dialysis, the last 1 hour, why the last hour? Because the first 3 hours, they were like they had a lot of volemia that has been removed. The last 1 hour, they're at the heart is better, like the volume of the blood is the least possible. So I gave them 45 minutes of, we had these pedals that they could actually pedal.
Yes, pedal, yes.
Yes, while lying down in the bed. And I had research assistants helping patients remember that they continue. And they actually did 45 minutes. And the aim of it was, at the time, was not so much sarcopenia, but rather altogether the patient outcomes, clinical outcomes. And I'm happy to say that all those who had edema gone away, all those that had hyperphosphatemia, a more efficient hyperphosphatemia, because of that, they started, their appetite improves, and because of that, they started eating more protein because they could tolerate, and we could improve the protein intake because we didn't anymore fight with phosphorus, right? Because protein comes with phosphorus. And overall, it was a randomized controlled trial, and that protocol did fantastic. And I highly recommend interdialytic exercise. And muscle cannot be produced without exercise. We can give it as much as protein as we need, but if we're not exercising, and even sometimes, they're like EMS, they put some electrodes to stimulate the muscle, that is not bad, but that is not enough. It is not enough. The muscle has to move on its own to produce and to regenerate. So definitely they come hand in hand.
If they cannot do exercise, they can do dancing exercise. So dancing, sometimes it works.
Whatever it is that they prefer. At the time, we did this because we could control the exercise and make sure that they actually do it 3 times a week, 45 minutes.
Professor Wafa?
Yeah, thank you.
Dr.
There is
Elizabeth
another-
wanted to say something.
Please.
Thank you. Yes, I would wanted to add that indeed the muscle is very important when we talk about the proteins, but like I showed, the amino acids are also very important for the GI tract, because the GI tract is a rapidly changing cell line that needs to renew the cells. You know, when you give a patient chemotherapy, think about the impact on the rapid changing cell lines. So we are also providing building blocks to renew the cells in the GI tract, but also in the kidney. So I really am very happy with all the proof that we have on the muscle, but I think that we also need to look at the provision of amino acids for building the gut and building the kidney. So I think that we have a muscular component, but also a win-win situation on the organs.
I agree. I wanted to say the same. You took it from my mind. Thanks so much. There was maybe Dina, she's asking, or Diana, maybe it is outside that topic, but if the patient with 1 kidney atrophy functioning so good should be treated as CKD patient, if yes, can you tell her the protein calculation for her? Is it that 0.6 or to 0.8 kilogram? It's for Professor Mireille and Professor Elizabeth. Anyone, please. You want to ask the question again?
I think I have to answer this question because they are talking about pure nephrology. It is not a nutritional one. So by definition, chronic kidney disease is by estimated GFR below 60. Whatever the ultrasound finding, if you have a laboratory finding of an estimated GFR below 60, you put the patient into the diseases of chronicity of chronic kidney disease and apply for that low protein, unless the patient has a hypercatabolic state and other possibilities. So CKD is CKD by estimated GFR.
Any additions? Any comments? Okay. Dr. Hisham, you want to say the following question?
Yes. From that, how to tackle post-renal transplant hypercholoremic metabolic acidosis. We are here going the question for Manu.
Yes, is a good question. I think the treatment is the same as you would treat it in any other patient. The question here is why did the patient develop hyperchloremic metabolic acidosis? So was this related to saline infusion, maybe, of too much unbalanced solution? So I think that's important. Maybe it's related to tubular dysfunction or not fully recovered kidney function. So I think it's important to identify the cause, to identify the volemia status. And if saline is in play, I think we should switch it to a balanced solution. And then close monitoring of kidney function, kidney electrolytes to see. But basically, the treatment, I would say, is the same as in the normal situation outside the kidney transplant.
There's another question for you.
Yeah, so there is another question in iatrogenic hypernatremia in patients with hypervolemia. I think this is the classic one, which happens after a couple of days or maybe weeks in the ICU. So how to treat them? So you want to have free water clearance to solve the hypervolemia. at the risk of further increasing the sodium levels. So those are the tricky ones. If there is still ongoing fluid administration, of course, that's the first thing to stop, and to lower the chloride intake. So go for solutions with a higher strong ion difference as opposed to saline. And what we usually do in those patients is checking for the albumin levels. And if albumin would be below 30 grams per liter, we would go for hypertonic albumin supplementation up to 30 grams with diuretics and combination of diuretics. So metolazone, I think, is a thiazide. We use indapamide to have also sodium clearance, or a combination of diuretics. But sometimes you will see that it works 1 day, 2 days, that you can have a negative fluid balance by 1 liter. And then these patients may end up on renal replacement therapy, hemofiltration, which allows you perfect metabolic control of your electrolytes. That I would only do in case of fluid accumulation syndrome, being any percentage of fluid accumulation with new onset organ failure dysfunction caused by the accumulated fluids. And this can be evidenced by an increase in the intra-abdominal pressure, by an increase in the extravascular lung water in the lungs with a high PVPI. So you look at the impact of the accumulated fluids. You can check for venous congestion, venous hypertension, try to do a VEXA score. And then I would simply put that patient on CVVH, because you're not going to solve it with the diuretics.
Yeah, diuretic failure, yes, so probably.
Professor Hisham?
Yes, I think we are coming to the end after 2 hours, so...
There's a lot of questions about the fellowship. I think Dr. Khalid will answer all of them at the end, the prices and all of this. But please, Professor Hisham, if you have any questions that we didn't...
No, I'm very happy that I'll be one of part of this very great webinar. We always say to our patients that 1 apple a day let the death away. So we can keep that on this part, and be in mind that too much of good thing is a bad thing. So we have to calculate everything and to have to put everything to the requirement, not overshooting and not less. Professor Khalid, the mic is yours to close.
Thank you so much, everybody. Thank you. It was an honor.
Thank you, Winnet.
Thank you.
Yeah, I would like to thank you all, and thanks for the attendees as well, and thanks for the attendees here at Boko Hotel. Now is the time to close, and see you in the coming webinar. We are planning to have a sarcopenia webinar in the future, and GI webinar as well, before starting our fellowship on May 26th. Try to utilize this exceptional promo code for 24 hours. It's a great chance, and we'd like to thank Dr. Amr Husseini for giving us this opportunity. And see you on the coming webinar. Bye-bye. Can end now.
Thank you very much.
Okay, bye-bye.